Good morning, Texas. This is Brandy coming to you from Florida. Sunny and nice weather. So, today we're going to be talking about navigating and selecting patients for the day. So, by this time, you should have already had 2 to 3 weeks of doing intense assumption of cares, learning the facility, learning the staff that you're working with, getting to know some of the physicians and their mid-level providers, and now you're ready to jump into morning clinical meetings. So after today, you will start going to morning clinical meetings. So make sure that the DON knows this. We've talked about this on our letter that we sent to the DON, explaining that we were going to have a couple of weeks without morning clinical meeting, and then we would start attending. So make sure you let her know or him know that you'll be attending morning clinical meetings starting tomorrow. So this is just trying to prep you for that meeting, and let you know what kind of patients you're going to be looking at for the day. Your goal at the end of morning meeting is to have 20 to 30 patients on a list, with those that are most important starred for the day, so that you know you need to address those. And the other ones that are on there, if you get time or if you haven't had a chance to see someone or someone went to dialysis, that you have other patients that you can see. Also, if tomorrow's list is smaller, those initial patients that you didn't get to see today, you can do tomorrow. So our list, we want as long as we can, and the most important are what we're going to focus on today. For the first 2 to 4 weeks after you start your morning clinical meeting, remember you're still finishing up your assumption of cares. So if you have a patient with a fall, that's a good time to do the assumption of care, and your chief complaint would be a fall, and you can address both at the same time. So this really allows you to do a little bit more acute patients while you're finishing up on your assumption of cares. So the first thing we're going to do in the morning, just like you've been doing over the last several weeks, is to go through your admits and your readmits for the day. So you would, if you took my thought on writing or printing out your face sheets, you would print out your face sheets either the night before or that morning, and you would see new admits for the day. So even though you're still doing your assumption of cares, your admits and your readmits are going to be your priority for the day. And then anyone that they called you about last night after you had already left, maybe they called you and someone was sick and you put some Zofran in place, or you ordered a chest x-ray and some Mucinex and we're waiting for that. Those are the first priority patients of the day. Usually between 7 and 8, 7 and 8:30, somewhere around there, you're able to make rounds in the building with those patients that you already know need to be seen. And then you're going to jump into clinical meeting. So make sure you find out what time clinical meeting is. And so they're going to be reviewing changes of conditions. You're going to be following along. Anybody that they say is of an issue, then we decide if we can see them. Anyone that's an issue, your name, you're going to write the patient's name down and then what their issue is. And you're going to star that if it's an important patient that needs to be seen. If they're having a slow, insidious weight loss, do we want to address it? Of course. Is it an emergency now? No. Can they wait till tomorrow or the next day? Perhaps. So that's where you get to make that decision. But we're going to determine our high risk patients. So our high risk patients would be anyone with a weight loss. So maybe we're going to run that report every single week. Anybody with new antibiotics, you're going to run that report at least Monday, Wednesday, Friday to see who's on antibiotics. Any new psychotropics. So if your PMHNP or your psychiatrist comes in and they put someone on a new antipsychotic, an antidepressant, anxiolytic, or a sedative hypnotic, we're going to want to see those patients 2 to 3 days after they've started on this medication. Anyone with a new fall is an automatic star on your sheet. You're going to make sure that those patients are going to be seen as well. And then from a risk management standpoint, which is usually falls, new skin issues, a resident to resident altercation. And then regrettably, I don't have a cheat on where we can get a wound report from Point Click Care. So this is where you're going to make sure that you've got that relationship with a wound doctor, that you've met him, that you've made contact with them, that you've exchanged contact information, so that when you're seeing the patient 3 days after they do a debridement or they start a new treatment, that you're looking at that. And if there's a change in wound status that's worsening, we're reaching out to them and collaborating, seeing the patient and following up that way. So our daily clinical meeting or evaluation of the medical records. So some people, you've got DONs, moving parts, clinical meeting changes. Sometimes you've got survey in the building where you can't have a full clinical meeting, or two of your unit managers have now worked on the med cart and there's really no clinical meeting. This is to show you how to go through and get that data yourself, but you should be doing this during clinical meeting if you have it. And if you don't, you should be doing it to get that information. So first, obviously, is going to be speaking with the nurses daily. Now, you don't have to run around and see all 6 nurses stations or 4 nurses stations. Make sure you touch base with the nurse each time. However, as you're on the unit doing your new admits, your assumption of cares, and any changes, you would want to say, hey, I'm here in the facility. Is there anything that you need? Always touch base with your nurses. So you're going to review your ADT list, and I'll show you what that looks like. But those are your admits and your discharges and transfers. And you can always refer back to this slide that walks you through going to the clinical, going to care management, and then going to your dashboard. And about halfway down for the people in Texas is your ADT list, and it's your admits, discharges, and transfers. You're going to review your labs every day. So if you're in 2 buildings and one is Monday, Wednesday, Friday, and the other is Tuesday, Thursday, every day you look at both buildings, both labs, every day, whether you're in the building or not. If you have a critical potassium that comes in today and you're not at the building until tomorrow, you want to know and address that immediately. So that's when you would put them on your agenda to see tomorrow, but you would address the lab today. You would implement potassium and a follow-up lab. You're going to review the risks. And so you would go under clinical, care management, risk management, and active, and you're going to be able to see all of the new falls, skins, behaviors that have been put in so that we can address those patients. Again, as we're going through these sections, it walks you explicitly through the step-by-step of how to get there. We're going to review antibiotics. Do that at least Monday, Wednesday, Friday, at least twice a week. This isn't something you'd want to do once a week because someone could be coming off of antibiotics and you're not aware of that. And it walks you through how to get there. Same thing with psychotropics. 2 to 3 days after your PMHNP psychiatrist, they leave the facility and they've made medication changes, you would want to see that patient just to see how they were doing. Again, we don't do visits for a routine follow-up. We're doing them for clinical necessity. So we'll go through what that looks like. And then we're going to review weight losses for the week. When I talk about any of these visits, remember that I'm talking about any patient that has Medicare either as a primary or a secondary. Any patient that is a Medicaid-only patient gets seen once a month. And so the medical director would be addressing the labs, the risks, the antibiotics, the psychotropics. And so while you can let them know that they're having abnormal labs, and you would want to collaborate with them on that, you're going to clear the labs, but you're going to want to make sure that the physician is aware of that. The only reason we would see a Medicaid-only patient is if there was an emergency and we were trying to prevent return to hospitalization. And then you would just go ahead and email me and let me know that you saw a Medicaid patient related to an emergency. Now, an emergency is not a positive urinalysis. It's not a cough that the nurses can call in. A true emergency is you needing to start an IV line or you needing to initiate oxygen therapy because the patient is in crisis. So just remember, everything we talk about are Medicare patients, either Medicare A or Medicare as a secondary. So I don't want there to be any confusion. So when you go in to review your ADT, you're going to be able to date range that. It actually goes up to 28 days. So where I do rounds once a week, I date range mine to 14 days because I want to make sure I didn't miss anyone in that last day on day 8. But it goes 2, 3, 4, 5, 6, 7, 14, 21, 28. So you can pick that variety. So if you're off on Friday and you've taken a 3-day weekend, you can go back and see if anything was missing. So I usually print, and I've told you this before, I print face sheets for new admits. It gives you the ability to have diagnoses. You've got your demographics. Are they, what is their marital status? What is their religion? What is their previous occupation? And then you've got all of the other information on that. But in order to figure out who are your admits, discharges, and transfers, you're going to go under the clinical tab. You're going to go under care management, and then you're going to go under your dashboard. And about halfway through, for my Texas people, you're going to find admits, discharges, and transfers. So this is what you're going to look for, and you're going to date range it for however long you want. It automatically defaults to 3 days, but of course you could extend that out. So admits that come in over the weekend, Friday, Saturday, Sunday, they need to be reviewed meticulously on Monday morning. Rationale behind that is when they come in, sometimes the nurse who has 25, 30 patients, she's got an admit on top of that. We want to make sure that all of the medications came over correctly and that there is no misunderstanding from what the hospital says for discharge medications from what we've put into our medical record. Sometimes they may send over a medication record and then they send over a new one when the patient discharges if things have changed within the last couple of hours prior to discharge. So make sure you're checking that. Make sure that the follow-ups to the ortho or oncology are actually being put in the computer so that we can go ahead and write that in point-click care. Make sure that antibiotics have stop dates. It's often that we see Keflex 3 times a day and there's no stop date on that. So make sure you're looking for that, you're doing the searching for that, or that you're reaching out to find out what that stop date are. If they're a readmit and they went to the hospital and they come back, make sure that the medications they had before they come back with. So obviously, if you had a patient on Lasix that had acute kidney injury, you don't restart them on the Lasix. But if you had vitamin B12 or vitamin D3, or they were on a Med Pass or a Magic Cup or an Ensure or a Prostat, that we reinitiate that. Make sure that if they're on a statin and they did not have rhabdomyolysis and the statin wasn't intentionally taken off, and it doesn't say discontinue on the order, but it was just left off. Make sure that those medications, if applicable, are put back on the record. Sometimes the hospital is focused on just the rationale on why they were there, and they don't address the long-term medications that they're on. Make sure that all medications in the computer have the right dosing on them. Remember, you're the provider who does the medication reconciliation. This is your name on the medical record. This is your name that is on the bottom of each note that you write. So those medications that are listed above, we want to make sure that those are the correct medications with the correct dosing and with the correct diagnosis. We're not going to use Xarelto or Coumadin for a diagnosis of anticoagulant. And sometimes the nurses don't know what that is. So they see that it's an anticoagulant classification and they hand type in anticoagulant. You're going to look to see if they have AFib or if they've had a PE or a DVT, and we're going to write that diagnosis in using the magnifying glass, making sure that that diagnosis is in point-click care, so that under your medical diagnosis, when you pull in your notes, that will come in from note to note to note. We went through that on initial orientation. Any medications that require labs, schedule the labs for the morning so you get them tomorrow morning. So your routines, but then if they're on thyroid, did you get a TSH, and do you need a thyroid panel? You may not, but did you get what you needed? If they went out for 2 days and came back and they have an A1C from 3 days ago, do you need a new one? No. But if you don't have a recent one within the last 90 days, we'd want to get one. Any vitamin B12 or D3 level, any statin, we would want to get a lipid panel on. Anything like Crestor or high dose statin, we'd want to get a CRP and a SED rate for. So make sure that we've got medications that need labs, that we actually order them. Discharges that we were expecting, they told us on Monday that the patient was going to be leaving, and we actually did the face-to-face on them on Monday. Now that note stayed opened and we didn't close it. It was dated on Monday. We did the face-to-face on Monday. When we come in on Thursday and we see that they've been discharged, we go back to Monday's note and we lock and close it on Monday. That's the day we did the face-to-face. But you never close a discharge before the patient's discharged, because the patient may not discharge. So when we're looking at our ADT, our admits, discharges, and transfers, when we see that they've been discharged, then we can close that note. But we don't close it for the day they left. We close it for the day that you did the face-to-face. And then any payer changes, it is helpful to see that. If you have a Medicare that came off and now is Medicaid, if you have a Medicaid pending that we've been waiting for their Medicaid to come in, and now they've come and they've changed to Medicaid. Those are things that we want to take note of, because and if they don't have Medicare and they've been Medicaid pending, now you can see them and you can start seeing them on an every month basis. Admission notes should include the reason the patient was in the hospital, any significant findings, and then why they're in the SNF right now. Why the patient was in the hospital, specific surgeries, or the reason the patient had an extended stay are all important things to have in the chart. 4 to 5 sentence paragraph, and we've actually created that hospitalization section so you can put that information in there. Go ahead and utilize that. But after about 30 days, you're going to delete that out. And once it's deleted out, it won't move from note to note. And the reason behind that is we don't want to have notes that look like copy and paste. So while the first few we're reiterating while they were hospitalized and the rationale why, we don't want to have that here on out. After they've been here for a month, now they're ours. And so we already have established care with them, done follow-ups with them, and so we don't need that on there anymore. If you know their discharge plans, go ahead and write them. There's a good place for that to be. And if you're doing an assumption of care and their long-term care, write why they're long-term care. And it can be one brief sentence on the patient's not able to go home because they have no family support, they have dementia, they have confusion, they're not able to take care of themselves, they're not able to do ADLs. When writing an HPI, this is something that I see on many notes, that the HPI only has 2 to 3 sentences, and it's stating patient is lying in bed with no acute concerns. Why are we seeing the patient? That's part of your HPI. So if you're doing your monthly visit, what are you assessing them for? If you're assessing them for diabetes, for hypertension, and AFib, go ahead and put that in your HPI. Now, do not make your HPI a novel. That's not the point. The point is to at least address the issues that are of concern. Remember, your initial evaluation for your patient is always going to address each medication. But after that, you only need 3 to 4 assessment of plans. So what are you seeing the patient for? It cannot just be for one thing. It has to be for multiple things. So 3 to 4 assessment of plans. And so we would want to address that under the HPI section. If it's something acute, go ahead and use old carts. It's a very good way to explain and make sure that you have everything identified in there. If you've got dementia and they're not on dementia medications, this is where you're going to put that information, because you're not going to put it under assessment and plan, because there's no plan, there's no medical intervention you're doing for dementia if they're not on medications. So we are only medically managing these patients under assessment and plan. So go ahead and put that, that their increased need for ADLs, and put that in your HPI. If they're having any mobility issues, if they're working with therapy, put that in there. Any sleep issues, mood issues, appetite issues, any response to treatments, medications. If they're refusing meds, this is a perfect place to put it. Comment on effectiveness or side effects or adherence issues. I always say use your negatives, but don't use a whole list of negatives like you would on a review of systems. If they've got cardiac issues and you're addressing congestive heart failure or you're addressing hypertension, then that's where you could say no chest pain, no chest palpitations, that sort of thing. What you're not going to put is no nausea, vomiting, and diarrhea behind your cardiac issues, unless, of course, you've started on a new medication and those are side effects. On the other hand, if you're doing COPD, your negatives would be dyspnea, shortness of breath, chest pain, and again, you wouldn't mention the nausea, vomiting, and diarrhea. But if you just started them on Zofran, then you can say the patient is reporting nausea, no diarrhea noted, no vomiting, and does complain of constipation. So you put your complaints and then you put your negatives behind it. So make sure your negatives are in the right spot. And then if they've had any recent hospitalizations, falls, infections, medication changes, or labs that prompted today's visit, make sure you're documenting that under your HPI. Now, your chief complaint wouldn't be lab review. It wouldn't be abnormal labs. Those don't have ICD-10 codes with them. It would be hyponatremia, hypokalemia, that sort of thing. So make sure that your chief complaint is actually appropriate for it. So if I can move this down, under your labs, this is something you're going to look at every single day. So in order to get there, you're going to go to clinical, which is here. You're going to go here to care management, and a little below your dashboard, you'll find labs results. So if there's unmatched laboratories, that means either the name was spelled wrong or there's an incorrect birth date. You click into the patient and you can find it, and it says, would you like to match this patient? And you say yes, and then it pops over into the unreviewed labs. That's when you're going to review them. Now, I have talked to your chief nursing officer and your vice president of operations. They are aware that some facilities have unreviewed labs that are prior to you getting there. There is a ad hoc copy that they have that they can do so that we can get all of those signed off, and those will not be under your accountability. So the DON or nurse administration would sign off all of those and start fresh. That being said, from the day you start taking over, that would be tomorrow. When you're watching this video and you start going to clinical meeting, that starts tomorrow. You will be accountable for making sure those labs are signed off on a daily basis. So you're just going to come in under the lab and you're going to view results, and then you're going to click your actions and you're going to look at them. and then you're going to mark them as reviewed. When you do that, it puts your name, your date, and then the time on there saying that you've reviewed that lab. When that's on there, that means you're taking accountability for the lab. So if you've got significant issues that need to be resolved, you need to stop right then and there and resolve those issues. If you've got something like an abnormal B12, you put their name on your list and you just put low vitamin B12. They don't have to be starred. It's not an emergency. You can put vitamin B12 in tomorrow. If you've got a low potassium, 2.8, 2.9, those are emergent stops. It's a cold stop. You go into the patient, you order the potassium, you order a follow-up potassium lab. So make sure you address all significant results, but then every result is marked as reviewed and then you close it. Under the risk management tab, it says clinical care management, risk management. So you're going to go again under clinical and then under care management, which is right here. And then right below labs, there should be risk management. When you click into risk management, it automatically brings you to the summary. So the summary is actually the teal color. You're going to click active. And once you click active, it will have a drop down of all of what is current. So you're going to be reviewing the day before or 2 or 3 days before if you haven't addressed them. And those are going to be your falls. Those are going to be your new wounds. So sometimes they haven't gotten to resolving them. So there may be several months worth of them and you just scroll to the bottom to get to the most recent. However, in order to get to them, you only need to do the last couple of days. Starting tomorrow, when you hit your clinical meeting, what you're going to want to do is just do for the day before. If it's a weekend, then you do for several days before. Those falls need to be seen today. The new wounds need to be seen today unless the wound physician is in. Those are the patients that need to be starred on your list. Fall documentation is one of the most important reasons why we are there on a regular basis, is so we can see patients when they fall, see what's going on, see if their blood pressure was maybe a little low, if we've started them on a new medication, what was the cause of the fall. So falls, wounds, weight loss, they're one of the highest litigation reasons to sue a nursing facility, as well as the physician and us. So make sure that we've got information that's there. So you have a snippet under your HPI, and you also have a snippet under your assessment and plan. Utilize what is appropriate. If you're doing a discussed with patient fall safety interventions and the patient has dementia, that part of the snippet needs to be deleted. But what is known about the fall? What does the patient say happened, fell? How were they found? That needs to be documented. A thorough assessment of injuries, including a lack of injuries. So we're going to talk about skin. We're going to talk about mobility, so your joints. And then you're going to talk about cognition. Again, all in the snippets. You're just editing them. And then under your assessment and plan, a discussion with the facility staff on fall prevention strategies, if you've discussed that and you have that. Excuse me. So on your antibiotics, this is something you would want to do. I would do at least 3 times a week, because you're going to want to document on your antibiotics. But there's a report. You go to order listing and then you go select date range. So you should be doing it week by week, at least see your antibiotic patients every week. But if you can see who's on antibiotics, that's ever changing. So here is your dashboard. Usually you go under clinical to find your patients, but you're going to go under reports to find your antibiotic list. You're going to go under order listing report. There's a whole list of reports you can choose from. This is the one you'll choose. You're going to order the date range. You're going to select your medication class. And so when you select your medication class, it will have 3 things at the top and then like 60 things you can choose from. Just click infectious disease and it will give you anyone that is on an antibiotic, an antiviral, and then you're going to click apply and run report. All infections need to be documented at the start of antibiotic therapy. This is where we discuss symptoms and the location, as well as any pertinent negatives. And then during antibiotic therapy, we should be finding out if there's any resolution or decrease in symptoms, as well as any side effects that have started to occur related to antibiotic therapy. Again, remember, diarrhea, if we don't address early on, could end up causing C. diff, which potentially could be a sentinel event. And then when you're completed antibiotics, you'd want to go back to the patient and do that follow-up note. Patient has completed antibiotics related to cellulitis in the left lower extremity, erythema, redness, warmth has resolved. Patient has decreased pain, decreased edema. So you're going to write those symptoms and how they've improved and any side effects that are related. So signs and symptoms of infection. So you're going to want to do local findings, systemic findings, atypical things to watch for with adults, and then complications to watch for. So this should be all part of your antibiotic documentation. So a couple of examples, signs and symptoms of cellulitis. I've got local findings, systemic findings, and complications to watch for. You can utilize some of this in your documentation. I've just given you a couple of random examples. Another example is a UTI. So local findings. So you can write what they do have and what they don't have. Atypical findings, systemic findings, and then complications to watch for. I have one for upper respiratory infection. I didn't do them all, but I gave you a couple that you could choose from. Psychotropics, you're going to want to see a patient 2 to 3 days after your PMHNP or psychiatry comes into the facility. So how do you find out who has new medication changes? You're going to go under reports, order listing, get your date range at least for the week. So do a week. So if today is the 1st of the month, you would do it for the 7th, 1st through the 7th, and then the 7th through the 15th. So make sure you're doing it at least once a week. You go to medication class, and instead of picking infectious disease, you pick psychotropics, and it'll give you your anti-anxieties, your antipsychotics. You click apply and then run report. Now, you're not going to get better starting an antidepressant in 2 to 3 days, but you do want to document any suicidal or homicidal ideations, any side effects that they're having. So they're likely not going to get better unless maybe if they're on trazodone for insomnia and you'd want to assess that, or Remeron for poor PO, you'd want to assess that as well. Anti-anxieties, if you start or increase, you should have a benefit of results at this point, at least a little bit less restlessness, or decrease or discontinue that. Sometimes you end up with rebound effects. So you'll want to document on that. And antipsychotics, you're surely not going to get a resolution of some psychosis. You're not going to get resolution of hallucinations or delusions, but you are going to document on side effects. You're going to document on sedation. You're going to document on restlessness. Some antipsychotics cause edema, bilateral lower extremities. And then sedatives, you should have some resolution. They should be feeling better. They should be getting a better night's sleep. So you'd want to document that. But you'd also want to document if they're being sedated in the morning, if they're having increased falls, if they have sleep hygiene issues. Your weight report, you're going to run this every week. So if Friday is your slowest day or Monday is your slowest day, you're going to run that. And it's the 1st of the month till the day you run it, the 1st of the month till the next day you run it, the 1st of the month till the next day. So the 1st to the 7th, the 1st to the 14th, the 1st to the 21st, and the 1st to the 30th, 28th. So you want to make sure you're running it from the 1st of the month to whenever you run that report. Run it every week. You're going to go to reports. you're going to go to weight and vital exception, and all of the vitals will be clicked when you click into that. Unselect them all and only select vitals. Select your date range, so it's a week at a time. So from the beginning of the month to the week, the beginning of the month to 2 weeks, the beginning of the month to 3 weeks. You run that report. Make sure you're documenting the number of pounds and percentage lost. Here's some examples of documentation under your HPI. The patient's lost this much percent and this many pounds in this many days. Document any noted reasons for weight loss. What is their diet? What is their supplements? Do we have appetite stimulants on board? Has the RD evaluated? How does the patient eat? Do they clench their teeth? Are they end-stage dementia? Are they only eating a couple of bites? Are they pocketing food in their mouth? Are they nauseated? Do they have no appetite? Are they depressed? Those are all things that we'd want to look at. Has the RD already given them a diagnosis of malnutrition? Have we gotten a recent CMP? We're going to utilize weight loss snippet under assessment. Then you're going to need to go into point-click care. Do they have a diagnosis of adult failure to thrive, sarcopenia, protein calorie malnutrition, cachexia, or weight loss? Any of those are important, and they don't get diagnosed by any other person. We're the ones diagnosing them. So do they meet criteria, and are we following up on that? Your wound list you're going to get from the wound physician. You're going to see them 2 to 3 days after they see them. We cannot duplicate care, so we're not going to stage them because the wound physician has. We're not going to measure them. We're going to look at their dressing, how it appears, any drainage, how the surrounding skin appears. If any issues are present, then that's when we call the wound physician. If it's a new wound, go ahead and assess it. You don't have to stage it, but describe it. We don't want to put stage 2 on there. And then when the wound team comes in 2 days later, it's a stage 4, and it's because we staged it incorrectly, not that the patient declined so significantly in 2 days. Make sure you get a treatment in place. Visits by payer, we've talked about this. The facility payer is this. This is also your place of service payer. So if they're Medicare, their place of service 31, and if they're any other payer, then they would be 32. So this is the facility payer. This is us. We are here. Look for a Medicare beneficiary number. So Medicare A, you can see them 3 times a week and with new changes. If they're long-term with Medicare, you can see them when medically necessary. HMO, if they're needed, Medicaid once a month, hospice once monthly, and emergencies. Medicaid pending, none, emergencies only. How to check for who has a Medicare beneficiary. I printed that list off when we started 2 or 3 weeks ago, but this is how you can do it. You're going to go to reports, and then you're going to go to your resident list because you want a resident list. Make sure you click active or current patients. You don't want a list of every patient ever been there. And then you're going to want to just select this Medicare beneficiary ID and run the report. And then here is your Medicare numbers. The ones that don't have them, they don't have Medicare. So you need to check and see what their payer source is. And likely they'll only be allowed either 1 visit a month, or they won't have a payer, and then the physician that is in charge of them would take care of them. That's why they get that facility stipend. So if you have any questions, and I know that was fast, but if you have any questions, let me know. Here is my phone number, my email. You can always get a hold of me via text. If I am in a meeting or a Zoom meeting, I try to text you. I'm in a Zoom. So that means when I have a break or when I have a moment, I'll text you back, but I'm always available to you. Thank you for watching. I appreciate your time. I know that in-services like this are difficult. I try to put them online so that you can watch them at your convenience. And I'll also send you this PowerPoint so that you can have it to reference back on and get that instruction for. Thank you so much for watching. I appreciate it. And Texas, welcome to the team. Have a great day.